بسم الله الرحمن الرحيم. أعزائي طلبة المرحلة الرابعة، السلام عليكم. We proceed for the second lecture. Today our lecture regarding the testes and the scrotum. First of all, we should take an idea about the anatomy of the testes. As you know, the testes develop in the retroperitoneum below the kidneys in the early fetal life. It is abdominal organ. The Wolffian duct becomes the epididymis and the vas deferens. The precursor for the gubernaculum, this which pulls the testes to the scrotum, it develops as a fold of peritoneum. The maternal chorionic gonadotropin hormone stimulates the growth of the testes and may help or stimulate its migration to the scrotum. Blood supply of the testes. The testicular arteries from the abdominal aorta on the left side, while from the renal artery on the right side. The venous drainage finds its way to the left renal vein, the left testicular vein to the left renal vein, while the right testicular vein go to the inferior vena cava. The epididymis on the posterior aspect of the testis. Normal positioning. The epididymis posterolateral to the testis and palpable as a separate structure. The vas deferens takes its origin from the epididymis, continuation. The tail of the epididymis. The epididymis, three parts: head, body, and tail. The tail is continuous with the vas deferens, or connect to the vas deferens. This will go through the inguinal canal. In the inguinal canal, the vas deferens is invested by the cremastic muscle, which is a continuation of the abdominal muscle, anterior abdominal wall muscle, the external oblique, and along with the other components of the spermatic cord, the vas go its way toward the prostate and ejaculatory duct, as you know. We talk about the incomplete descent testis and ectopic testis. Should be differentiated. Incomplete descent of the testis, it is arrested in some part of its path to the scrotum, normal pathway to the scrotum. When it is arrested in any side, this is what we call it incomplete descent of the testis. While ectopic testis, this is mean the testis will be abnormally placed outside this path, either to the root of the penis, sometimes perineum, in the inguinal region, any area on this, but it is away or outside the normal path. The incidence of incomplete descent of the testis, undescending testis. About 4% of boys are born with one or both testes incompletely descended. Half of this percent, the testes will reach the scrotum during the first month of life, but fully descent after that is uncommon, unlikely. 10% of unilateral cases there is family history. We talk about the pathology. In case of incompletely descended testes, definitely the scrotum is poorly developed. The epithelial elements of the testis itself, if stay undescended, and later on in the puberty will become immature. The epithelial elements immature histologically, and maybe lead to the irreversible destruction or damage that affect or halt the spermatogenesis and limit the production also of the androgen. Also, in addition to that, an incomplete descent tests are left without surgical intervention, without descent it to the normal position, may be also poorly developed and may be atrophied later on. In case of incomplete testes brought down in the early childhood, often the function is satisfactory. I mean, may we preserve the function of the testes if we do early surgery at the age of first year or at before the 5 or 6 years, I mean before the school age. Clinical features. The condition is more common in the right side, maybe bilateral in about 20% of cases. Secondary sexual characteristics are typically normal. If unilateral, definitely because the other testes. And even if it is bilateral, secondary sexual characteristics are normal because the cells which is responsible for the androgen, it is preserved. Okay? Mainly affect the germ cells for the spermatogenesis, while the Lading cells responsible for the hormones, it is preserved. The testes may be, during the examination, maybe, in the case of undescended testes, may be intra-abdominal, and this is lying extraperitoneally above the internal inguinal ring. We cannot palpate it, but we can detect it by ultrasound or other physications, for example, MRI or so. Or maybe in the inguinal, in which case it may or may not be palpable, if it isn't. Or in the superficial inguinal pouch, in which case it must be distinguished or differentiated it from retractile testes. In case of retractile testes, the scrotum is normal when we compare it to patient with undescended testes, which is underdeveloped. Okay? In case of retractile testes, we can gently melt the testis from its position in the inguinal region to the bottom of the scrotum. And this is, as you know, we can't do it in case of undescended testes because it is with short cord. In infancy in general, most inapparent testes are retractile. يعني مو كل اللي احنا نشوفه انه بالاكزامينيشن شفنا انه ماكو تيستس باي لوكينج هذا نقول this is undescended. Mostly it is شنو retractile. They are normal, as you know. In this condition it is normal and require no treatment. What are the hazards of incomplete descent? Maybe first of all, sterility, especially when there's bilateral cases. In case of bilateral and intra-abdominal testes, so the patient may be sterile in the future. Pain may be as a result of trauma, or may be associated with indirect inguinal hernia. About more than 95% of those patients with undescended testes, it is associated with inguinal hernia, or at least inguinal hernial sac. Also, there is a liability for torsion. Also, when the patient present with undescended testes and develop epididymolysis, especially in the right side, maybe this is difficult to differentiate from acute appendicitis because it is mimic to the acute appendicitis. There is a chance of atrophy of inguinal testes before puberty because of the repeated minor trauma. Also, there increased liability to the malignancy, I mean cancer, which is more common in case of incomplete descent testis. So when we do orchiopexy for those patients with undescended testis, this is not change the chance of malignancies, but it is improve the prospect of early diagnosis. I mean early detection if there is any malignant changes or abnormal increase in abnormal increase in the size of the testis. A treatment of undescended testis or incomplete descent testis by orchiopexy, in which we explore the testis and we fix the testis to the normal position in the scrotum, and should be should be in the early life, but after the age of 1 year, to avoid the risk of the surgery as anesthesia and the surgical anesthesia during in early months of life. So because when we operate on the tiny patient, maybe there is a possibility of danger for his life because of anesthesia or something else. So we do the surgery after 1 year, and the testis should be brought down into the scrotum before the boy starts the school. Another subject, we talk about the testicular torsion. This is one of the top emergencies in the urology because, as you know, if there is torsion, this is mean impaired the blood supply, and there's just of the gangrenous testis or damage to the testis, and you know, and this is a very miserable condition. Testicular torsion is most common between the age of 10 and 25 years of old, although a few cases occur in infancy. I mean, during the infancy, maybe there is a chance of the testicular torsion. The symptoms vary with the degree of the torsion. I mean, the degree of the torsion may be the patient with one twist or 2 or 3 twists. I mean the rotation of the testis, when this is if increase the number or the severity of this twisted testis may be associated with severe pain. Most commonly there is a sudden agonizing pain in the groin and lower abdomen, and the patient feels nauseated and may vomit. This is very important to us. Should put in our mind there is a possibility of testicular torsion to prove otherwise. Torsion of a fully descended testis usually easily recognized by examination. When looked to the scrotum, the testis seems high, and when we palpate, in addition to the tenderness of the testis and the epididymis itself, there is also tender and twisted cord. We can palpate above the testis. This is mean there is a twisted cord, I mean twisted append, a twisted testis. In case of other conditions mimic to the testicular torsion, for example, in mumps orchitis, in the examination we found the cord is normal, not thickened as in testicular torsion. The onset of the redness of the skin and a mild pyrexia may result in the condition being confused with epididymal orchitis in older patients. Okay, later on, if neglected, I mean, or the patient not present late, and there is redness of the skin and there is presence of the pyrexia as reactionary to his condition, may be confused with epididymal orchitis. But in those patients with epididymal orchitis, there is usually history of urinary tract symptoms, urinary tract infection symptoms, for example, dysuria, which is associated with urinary infection. During examination, to differentiate epididymal orchitis from the testicular torsion, when we elevate the testis in case of epididymal orchitis, there is a relief of the pain. Okay, while this is not differ in the severity, or may be worse in the case of the testicular torsion. Should also put in our mind other differential diagnosis very occasionally maybe the testicular torsion mimic to the small tense strangulated inguinal hernia, which is compressing the cord and causing compression of the papilliform plexus. Also, this should be put in our mind, but it is rare. How to confirm the diagnosis in case of if the patient there is a doubt and present late? We send the patient for Doppler ultrasound. This will confirm the absence or presence of the blood supply to the affected testis. If it is absent, this is most probably as a torsion. If there is any doubt about the diagnosis, the scrotum should be explored without delay to preserve the testis. When the patient presents early, the treatment, we try to untwist the testis by gentle manipulation. We try to rotate the testis. If the patient if the pain subside and the patient get relief, okay, this mean the manipulation is successful. And at this time, the absence of this pain, this is put in our mind. This let us we are feel the testis is out of danger. This is a good sign, and we can arrange an operation to make fixation of the testis to avoid a recurrence of the torsion. As you know, if there is testicular torsion, should put in our mind there is anatomical predisposition for this condition. So we need to do fixation of the other testis because maybe the same abnormality here present in the other testis. So every patient presented with unilateral or the testicular torsion, when we do for him orchiopexy, I mean surgical intervention, we do orchiopexy for another or the other testis to avoid the happen or the testicular torsion in the future. If the patient presents late and there is infarcted testis, I mean damaged, gangrenous, so the testis should be removed and the patient consult later on to prosthetic replacement for psychological feeling. There is another condition mimic to the acute testicular torsion, what is torsion of the testicular appendages. And this is sometimes mistaken for acute epididymoorchitis, may be mistake because the presentation of this condition is not so severe as the testicular torsion, so maybe mimic to the epididymoorchitis, and this is also need good evaluation and the motion. Then the patient in this condition, there is the twist of the appendix of the testis, what we call pendulated hydatid of Morgagni. In this condition, the patient need surgical intervention in form of ligation of this appendix and amputation of the twisted appendages, and this will result in a cure of the condition. Another condition we found in the young boys about 4 to 20 years old. Most likely we found it's in the summer season and should be differentiated from the testicular torsion. In this condition, the scrotum is the patient present with very swelling of the scrotum is very swollen and redness, but there is little pain or tenderness. The swelling may be extended into the perineum, groin, and the penis. It is thought to be an allergic phenomena, maybe insect bites or something else. Occasionally there is eosinophilia. The swelling subsides after a day or so, but there is a chance of recurrence of this condition. We talk about another condition, what we call varicocele. What's the meaning of varicocele? Varicocele is a dilatation of the veins during the testis. As we know about the surgical anatomy, the venous drainage of the testis and the epididymis by forms papilliform plexus. When the veins drain the testis and the epididymis forms the papilliform plexus. The veins becomes fewer as they traverse the inguinal canal, and at or near the inguinal ring they join to form one or two testicular veins, which pass upward behind the peritoneum. The left testicular veins empties into the left renal vein, the right into the inferior vena cava below the right renal vein. The testicular vein may have valves near their terminates, but these are often absent in case of varicocele. There is an alternative collateral venous return from the testis through the cremastic veins, which drain mainly into the inferior epigastrix. Okay? Why this is more common in the left side? Because, as you know, because it drains to the left renal vein, and this is more perpendicular, okay, and long journey, and maybe a possibility of compression of the sigmoid colon. All this is a help, or maybe give a chance for high incidence of the left side, the varicocele, more than the right one. Etiology: most varicoceles present in adolescence or near adulthood, usually on the left. In many cases, the dilated veins are cremastic veins and not part of papilliform plexus. Okay, so during the surgery, we found, or when we do the open surgery, we try to make ligation of the cremastic vein before we start to ligation of the papilliform plexus. Sometimes obstruction of the left testicular vein by renal tumor, or sometimes after nephrectomy we do ligation. This is cause later on varicocele. But in this condition, characteristically, the varicocele does not decompress in the supine position. When do the examination and ask patient to in supine position in case of varicocele, which is not due to this lesions, not due to malignancy, or maybe empty, okay, due to gravity, okay. While in this condition, because there is permanent obstruction, so the patient, when they change position in the supine position, there is no decompression of these veins. Clinical features: varicocele is usually symptomless. Many persons or population, or they maybe have this varicocele and not without symptoms. They no effect of spermatogenesis. They get gestation or they have children. So the most varicocele is usually symptomless, but there is maybe an annoying dragging pain sometimes if it is severe and cause a dragging pain, especially when the patient is standing for a long time, and this has become worse if it is unsupported, the test is unsupported. The scrotum in the affected side hangs below or lower than the normal during examination, and on palpation with the patient standing, the varicocele plexus feels like a bag of worms. There may be cough impulse during examination, maybe cough impulse positive. It is widely believed that varicocele causes infertility. There is impression or belief that the varicocele causes infertility, but the evidence is inconclusive. Varicocele and spermatogenesis. Of all the possible causes of primary infertility, oligospermia. Oligospermia is one of the most difficult to treat because varicocele is relatively common. Varicocele, as we mentioned, we said it is a common. Some of those with oligospermia have a varicocele, okay, and it is tempting to blame this for infertility because it is a common varicocele, and some of those patients with oligospermia have a varicocele, so they try to blame this for the infertility. Perhaps the presence of unilateral varicocele somehow interfere with the normal temperature, as you know, control of the scrotum, which keeps the testis at some 2.5 centigrade below the rectal temperature. Unfortunately, there is little evidence that varicocelectomy improves the semen quality or the rate of conception. Okay? Treatment. Normally, if not any patient with varicocele and there is with no symptoms in surgical, so is not indicated for asymptomatic varicocele. There is indication for varicocelectomy, 3 indications. If the patient feel pain, dragging pain, and this is what miserable to the patient, I mean if the pain bother the patient, so this is indication for the surgery. If the patient subfertile patient, oligospermia or adenospermia or something else, and there is evidence of varicocele, so treat varicocele and see if it is if the patient get benefit from it or not. And the third indication is cosmetic, because in advanced cases or in severe cases there is an ugly shape of the scrotum and even maybe ulcer or something else, so we do for varicocelectomy as cosmetic cause. The simplest procedure, there are many procedures for it. There is open cutting, or there is laparoscopic, and also embolization. The simplest procedure is laparoscopic ligation of the testicular vein above the inguinal ligament, where the papilliform plexus has caused into 1 or 2 vessels, become 1 or 2 vessels, so we can ligate it by laparoscopic. Or sometimes, if there is facilities available, embolization of the testicular vein under radiographic control is probably the treatment of choice. But in our situation, we do open surgery. I mean either inguinal or what we call subinguinal, just below the inguinal or ring, or scrotum. Okay, and another procedure, what we call paloma. This is like the incision in of the appendix on the left side, for do ligation of the testicular vein or papilliform plexus accordingly. Because of the presence of plentiful collateral veins, I mean large number of collateral veins, so the recurrence is common after all types of varicocele surgery. There is chance of recurrence. Thank you and stay home.